Thank you for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by the Center for Substance Use Training and Telementoring, CSTAT, at Beeville, Texas. My name is Kato, and I will be helping the team facilitate today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots or More menu at the bottom right corner of your Zoom screen to find this option. If you're having trouble accessing captions, please chat Karen, our ECHO IT. Thank you to those who's already done this. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on navigation bar at the bottom of your window. And to all the Beeville, Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat. Or if you are joining by phone, please enter your email. Please email your phone number and name to beeville.texas@utesca.edu. And also, please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information you put in the chat will not be shared on those recordings. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've joined us today, we are just happy that you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. Or you can also use the chat to share your perspectives. There are a lot of us in the space, and so please keep your comments brief to allow others a chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. We are exploring other forms of CEs, so if the types I just listed are not relevant to your profession, go on and fill out the survey to let us know if you need CEs, and if so, what kind. All participants filling out the survey will be automatically entered into a drawing for a $30 Walmart gift card. And today's session will start with a presentation from Dr. Garland Gerber on adverse childhood experience explained for public safety personnel. And following that, we'll hear a case presented from Dr. Gerber. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage each of you to share that during our discussion so that we can learn from each other in this space. And with that, we'll do some introductions. Jeremiah.
Hi, everybody. Jeremiah Golka here, Executive Director of the SHIELD Training Initiative. We do operational safety and health trainings to help reduce stress and burnout for folks responding to overdose crisis and other drug-related stuff that you all work on. And glad you're here, and very excited to hear from Dr. Gerber because this is going to be really interesting stuff, and she has a lot of knowledge to bring to bear.
Thank you, Jeremiah. Cynthia.
Good morning. My name is Cynthia Mendiola. I am a retired federal probation officer, worked in the substance use disorder field with mental health. I also am a trainer and coach with the CCS Incorporation in core correctional interventions for probation officers and out in the field. Thank you for coming in. I'm excited about this session.
Thank you, Cynthia. Dr. Miramontes.
Hi, hello. I'm Dr. Dave Miramontes. I'm EMS Medical Director for San Antonio Fire. And we run an MIH program that does a lot of buprenorphine inductions and referrals of our folks into care. So happy to be here and be part of this space as an advocate for EMS, public safety, and fire.
Thank you. And Joe?
Yeah, I'm Joe Samaro. I'm the CEO of Solution Point Plus. We're a national training and consulting firm that operates at the intersection of where criminal justice and behavioral health systems meet. Former San Antonio police officer that spent the last 11 years full-time on a mental health unit, and excited to be here and a part of this. Thank you.
Julie?
Hi everyone, Julie Parrish. I'm the ECHO Program Manager for the Center for Substance Use Training in Telemetry here at UT Health San Antonio. I'm also a licensed chemical dependency counselor. Happy to be here with you all.
Thanks, Julie. And Andrea?
Hello, everyone. My name is Andrea Havler. I am a program coordinator for CDAT and for the ECHO series. Welcome, everybody.
And Jasmine?
Hello, everyone. My name is Jasmine Vidal. I'm an ECHO program coordinator. I work alongside Andrea. Thank you for joining today, and I hope you enjoy today's session.
Thank you. And last but not least, Dr. Gerber.
Was that my cue? I couldn't hear you. Sorry.
Yeah, sorry about that.
Okay. Hello, everyone. My name is Garland Gerber. I last Thursday just received my PhD from the School of Medicine at UC San Diego. Thank you. Thank you. Thank you to those. Long road. My background, I am a trained psychotherapist. I've been working in mental health and substance use treatment for over 15 years, made the shift because I wanted to make larger scale change. So decided to join my PhD program specializing in research on substance use. Let me go ahead. Can I go ahead and just start sharing my screen? So, okay. Okay. All right. I work alongside my research specifically looks at the intersection of occupational burnout among criminal legal professionals, so prosecutors, public defenders, and how that affects case-related practices, primarily among defendants with substance use disorder. I am so happy to be here. I've been working a lot in that section for a little while, as mentioned in my PhD, and this actually really speaks a lot to, this presentation speaks a lot to the clinical work that I have done for many years around mental health treatment, substance use treatment. So without further ado, let's get started. So here are some disclosures. We will shift through that. So I'm going to try my best within the next 20 minutes to help you comprehend the concept and origins of adverse childhood experiences, how the study was first initiated. We will try to analyze to our best ability the multifaceted consequences of ACEs, and recognize the complexities that exist and the limitations of the research, both the foundational research and existing research, and then understand the importance of trauma-informed care. So what is the ACE study? A little story time for you. So the initial idea was to look at the correlation between health issues and life issues. Stress, adverse experiences in early life. So a gentleman by the name of Dr. Vincent Felitti was a physician at the Department of Preventive Medicine at Kaiser Permanente in San Diego. He was initially involved in a program to help individuals lose weight. And during this program, he observed that some patients who'd experienced significant weight loss would suddenly drop out of the program and regain the weight. He was confused and wanted to understand the underlying reasons for this behavior. In his interactions with these patients, Dr. Felitti found that many of them had a history of childhood trauma. such as physical or sexual abuse. He realized that patients were using weight gain as a coping mechanism to protect themselves from unwanted attention and to build a physical barrier between themselves and others. So Dr. Felitti, along with his colleague at the CDC, Dr. Robert Anda, decided to investigate the relationship between childhood trauma and health outcomes. So they developed the ACE questionnaire to assess various adverse childhood experiences. The ACE study, which again stands for Adverse Childhood Experiences, began in the mid-1990s as a collaboration between the CDC and Kaiser Permanente. There were 2 waves of data collection between 1995 and 1997. And approximately over 17,000 participants. And the primary aim of the ACE study was to investigate the long-term effects of childhood trauma and stress on adult health and well-being. So the ACE questionnaire consists of 10 questions to assess adverse childhood experiences that individuals may have faced during their first 18 years of life. Including abuse, and you can see the 3 various components of abuse here, and including, neglect and also household dysfunction. Move on to the next one. So I pulled out some sample questions for you to see what is on the questionnaire. So this one, of course, measures neglect. Did you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or take care of you? And this is referring to if parents are in the household or the main caretakers for an individual. Did you lose a parent through divorce, abandonment, death, or other reasons? Did you live with anyone who was depressed, mentally ill, or attempted suicide? So this is, of course, looking for mental illness within the household. Did you live with anyone who had a problem with drinking or using drugs, including prescription drugs? So this is assessing for substance use within the household. Did your parents or adults in your home ever hit, punch, beat, or threaten to harm each other? So obviously domestic violence. And did a parent or adult in your home ever swear at you, insult you, or put you down? So this is emotional abuse, verbal abuse. And each question is 1 point. And so the range of the score that an individual can have is anywhere between 0 to 10. It's also really quickly important to note that I have heard that some individuals can and do utilize the ACE questionnaire to get a better idea of their client. Some social workers, but primarily I've heard some public defenders do use the ACE to get an overall view of what their client has gone through. And I just want to note that although this is widely used, particularly in clinical settings, it can be emotionally challenging for individuals to complete. As you can see, it requires people to reflect on potentially traumatic events from their past. So any sort of administration of the questionnaire should be approached with complete sensitivity, and support should absolutely be provided to participants when needed. So here you can see there is a graded dose response relationship between the number of ACEs a person experienced and their health risk behaviors. So in other words, what that means is that as the number of ACEs increase, so does the risk for negative outcomes. And so you can see some of the negative health outcomes here, including obesity, attempts for suicide, STDs, heart disease, even broken bones. And then also behaviors like smoking, substance use, and then also life potential. So graduation rates, academic achievement, lost time from work. So you can imagine the implications based on someone's ACE score. And you can see here on the right-hand side, the demonstration that as the points received, the score of ACE goes up, the outcomes also, negative outcomes also go up. So here's the ACE pyramid. The ACE pyramid represents the conceptual framework for the ACE study. The figure shows the development of risk factors for disease and well-being throughout the life course. So I will explain it in very simple terms first. So an individual experiences adverse childhood experiences, which in turn disrupts neurodevelopment, which in turn creates social, emotional, and cognitive impairment. So an individual may not be able to express their emotions appropriately, which may look like outbursts, violent behavior, struggling in school, struggling with social connections, which in turn oftentimes leads to adoption of health risk behaviors, which then unfortunately in turn leads to disease, disability, and social problems, which in turn unfortunately oftentimes leads to early death. Now, the reason why this occurs is because brief and temporary episodes of stress and adversity are going to happen in life, but the ideal situation is that these episodes are equalized by a supportive environment of adults. And this, in fact, is an important component in the development of a healthy stress response system. But when stress is prolonged and not buffered by a safe, stable environment or a caretaker, the physiological response, which includes extended periods of the release of a stress hormone called cortisol, it acts as a toxin and can disrupt neurodevelopment. This can disrupt the areas of the brain that are responsible for executive functioning skills like working memory, mental flexibility, self-control, and therefore it increases the risk for cognitive impairment and stress-related disease up to adulthood. Studies actually show that early childhood is particularly a vulnerable time for the neurotoxic effect of prolonged unsupported stress. And so disruption of neurodevelopment during this time can lead to lasting effects. So here are some of the consequences of ACE trauma that were found. As explained in the previous slide, exposure to continual high levels of stress causes physiological changes in the brain and body, and then leads to poor health related decisions. And primarily focusing on what we're focusing on today, which is substance use disorder, oftentimes leads to self-soothing behaviors, such as overeating, undereating, smoking, other types of substance use, which obviously compromise health and well-being throughout the years. So why are ACEs so significant? So the original study found that ACEs are common. Nearly 2/3 or 64% of adults have at least one. They don't occur alone. If you have one, there is an 87% chance that you have two or more. The ACE study finds a connection with childhood adversity and most chronic health, mental health, economic health, and social health issues. The study's findings were eye-opening and demonstrated a strong correlation between the number of ACEs and various negative health outcomes, as mentioned, and reduced life expectancy. Also, not only are scores linked to the adult's onset of chronic diseases, but they are also linked to a higher susceptibility to violence and being a victim of violence. And of course, you can think of all the implications around responsibility for large percentage of workplace absenteeism, which includes difficulty maintaining employment, costs in healthcare, the strain on emergency response, and what I treat often, which is mental health, along with criminal justice involvement. And I also wanted to note here that when toxic stress occurs, the brain is processing the trauma and stress and the associated chemicals released. It has the same impact, although the symptomology may be different. And so, for instance, individuals who've experienced multiple forms of abuse, one person, the symptomology may be exhibited as low self-esteem, low self-worth, which in turn leads to self-harm or self-harming behaviors, and leads to poor health and wellness choices. Whereas another individual who's experienced multiple forms of abuse may exhibit more violent behavioral issues, leading obviously to poor wellness and health outcomes. So what are some of the numbers? Here are some of the numbers associated with higher ACE scores. So an ACE score of 4 increases the risk of emphysema or chronic bronchitis to nearly 400%, and attempted suicide by 1,200%. High ACE scores are more likely to have more marriages, more broken bones, as mentioned, drug prescriptions, depression and other mental health issues, and autoimmune diseases. And here, this is oftentimes what we see, and unfortunately, in first responder situations, people with an ACE score of 6 or higher are at risk of their lifespan being shortened by 20 years. So focusing more on substance use, as mentioned, the risk of disrupted neurodevelopment oftentimes leads to adopting health risk behaviors and self-soothing trauma response, which is oftentimes looks like substance use and substance use disorder. And particularly substance use at an early age is common, oftentimes leading to the development of substance use disorder. So the research shows that the earlier you start using substances, the more susceptible you are to developing substance use disorder. So here are some examples. People with an ACE score of 4 are twice as likely to be smokers and 7 times more likely to develop alcohol use disorder. Each ACE increased in this study down here, cited at the bottom, each ACE increased the likelihood for early initiation of drug use by 2 to 4-fold. Compared to people with no ACEs, people with greater or equal to 5 ACEs were 7 to 10-fold more likely to report drug use problems, addiction, and IV drug use. And here are the percentages. The portion of substance use behavior that could be attributed to ACEs was calculated to drug use is 56%, addiction 64%, and IV drug use at 67%. So basically, 1/2 to 2/3 of drug use problems could be traced back to ACEs. And then narrowing further into a treatment population, people in treatment for addiction have a higher prevalence of ACEs than the general population. The study mentioned down at the bottom showed that among patients with substance use disorder, the rates of having suffered at least one ACE ranges from 85.4% to 100%. And I will remind you that the rate of having at least one ACE among the general population is 64%. So what makes the 85 to 100% range so concerning is that we know that if you have one, there's an 87% chance that you have 2 or more. So you could imagine the complexity and severity of outcomes for individuals in substance use disorder treatment, just based off the presumed ACE scores. So my first question for us to think about and perhaps discuss after is, Can you imagine what the statistics would look like among people who do not have access to treatment? So I would be incredibly remiss if I did not discuss some of the cultural and socioeconomic issues with the ACE study. In order to participate in this study done by Kaiser and CDC, what is it that you would have needed? And I will answer my question: insurance. So needless to say, 17,000 ACE study participants were mostly white, middle and upper class, college educated, and had jobs and healthcare. So again, my question, imagine what the statistics would look like if we carried out the study among people who had no insurance, Medicaid, or among individuals of other socioeconomic status. So often I have clients that say, I have 4 ACEs or I have 6 ACEs. Am I doomed? And there's an area of research called resilience research that shows that with neuroplasticity and the proper therapy and environment, the brain and body can heal. The brain is continually changing in response to our environment. So if toxic stress stops and is replaced by practices that build resilience, the brain can slowly undo many of the stress-induced changes. The difficulty here is that many individuals who have had lifelong adverse experiences and trauma feel uncomfortable in less chaotic circumstances and less chaotic environments. So that is a true hurdle of helping and treating individuals who have childhood trauma. But there is well-documented resilience research on mindfulness practices. Mindfulness practices can actually change the brain structurally. Exercise, proper nutrition, adequate sleep, and healthy social interactions in which first responders and counselors, therapists, we all play a role in healthy interactions with these individuals. The most important protective factor for children is a safe, stable, and supportive relationship with a caring adult. And needless to say, early intervention prevention is vital for adults. It would be a safe, stable, trauma-informed care environment. And also trauma-informed supports are absolutely key. So moving into our public safety information. So these following recommendations are for public safety agencies to improve interactions with individuals, both in the community and in their own organizations who have experienced trauma. These best practices are based on SAMHSA, or Substance Abuse and Mental Health Services Administration's concept of trauma and principles for trauma-informed approach. So the first one is realization, which is what we are doing here. Agencies and first responders need to work with the realization that trauma is a pervasive issue affecting individuals, communities, and organizations. The next one is recognition. So organizations and individuals who work within those organizations need to recognize the signs and symptoms of trauma to aid in the treatment and recovery process. And then the third one here is respond. So given the prevalence of individuals and groups experiencing trauma and adverse childhood experiences, an agency or individuals working within that agency should respond by being trained or training all members within the organization on best practices and policies to aid individuals who have experienced a lifelong trauma. And then very important, which I know is very difficult, especially in times of stress when you are responding to a circumstance, is resist re-traumatization actively. So following these best practices, some of those can be talking in a lower voice, recognizing if there may be a stance or position that may be less threatening or less traumatizing, that will mitigate re-traumatization. By identifying and avoiding environments and behaviors that may be triggering to these individuals. So finally, and I'm not sure how quickly we went through this, but one of the important things that I think we need to remember as first responders, public safety staff, is that we need to rethink and understand a client or a patient's concept of a caretaker. If they have not experienced what a true, safe, stable caretaker may feel like, not necessarily look like, but what that feels like. Considering the majority of individuals that we interact with, most of them, majority of them have some sort of adverse childhood experiences, given the numbers that I presented. We may be the one who can change their concept of what a safe, stable caretaker may feel like. It's really important to remember that substance use and substance use disorders are very often responses to trauma. We know from research that providing trauma-informed care, including understanding a person's possible ACE history, is absolutely vital to treatment adherence and outcomes. And many times, if a person does not have access to treatment, first responders and public safety individuals are often the first and only point of contact with individuals experiencing consequences from their trauma. And so all that to say that when we are interfacing or trying to help or support an individual who may be experiencing some sort of consequence from their trauma or substance use treatment or consequence, when these individuals are connected, provided services and trauma-informed supports, they become better equipped to recover. And that's it. Thank you.
Thank you so much, Dr. Gerber. That was a really informative presentation with a lot of data. Does anybody have any questions before we move on to announcements?
Oh, I'll keep my slide up so we can refer back.
Yes, Jeremiah. Let's see.
Hi, thanks. Dr. Gerber, that was great, really interesting. Thank you for sharing this with folks here. I think this is the kind of information that's really important to have. And of course it raises the doing trauma-informed response, even just it seems like the basic, just remembering that most anytime anyone's engaging with, particularly on the policing side, but also EMS and elsewhere, the problem is just making an assumption of the previous trauma is probably pretty safe bet, unfortunately. And one of the questions I want to have is about, this stress issue. If somebody's had, the constant exposure to stress, creating ACEs, so my sense is that, from what I've learned, is that the exposure to stress doesn't, in that kind of a context, doesn't make people quote unquote tougher. It actually kind of makes the stress trigger much more of a whatever featherweight trigger, hair trigger, or whatever you want to say. Can you talk about how those stress triggers become faster and can seem disproportionate and can feed the need for analgesia.
Yeah. So in there, that is in fact a misconception that, what doesn't kill you makes you stronger sort of concept. And particularly in childhood, again, when neurodevelopmentally that prolonged stress is toxic to not only the development of the brain, but the observations within the environment. So the learning process, right? And then also decision making. And I think, are you asking more in terms of neurodevelopmentally, or how do you want me to focus on asking or answering that question?
I guess maybe to kind of talk sort of kind of the why, and also the expression of kind of why the stress triggers can be kind of low and cause people to then have greater like respond to smaller stress as if it's really big stress, and how that can feed self-soothing.
So there's an area of the brain called the HPA axis, which is responsible for sort of monitoring and regulating stressors. And that becomes extremely sensitive when someone has experienced multiple prolonged circumstances of stress, which means that their stress response is more sensitive. So, when someone hears a loud noise, or someone is in an environment where they're not feeling necessarily safe or supported, that stress response is triggered. And when you're a child and you have not learned appropriate stress response coping mechanisms, and you don't have a safe space or safe environment, you end up utilizing whatever you can to calm the nervous system, right? Calm what you are experiencing, the dysregulation that's happening within your body. And so oftentimes what that looks like is self-soothing behaviors, right? So often I've had many clients in treatment who tell me, when I found X substance, so I'll use opiates for example. My parents worked all day. I was home alone. I didn't have any safe support system. I felt very lonely, neglected, right? When I found opiates, it was like that big, giant, warm hug that I never received, that I didn't know I was longing for, but I needed. And most of the individuals that I work with who particularly have opiate use disorder will say that it helps them feel safe and like nothing can harm them. And so that's an example of how individuals end up utilizing substances to self-soothe or seek what it is that they are needing.
Thank you.
Thank you, Dr. Gerber. Before we move on to the case presentation from Dr. Gerber, we have few announcements, really quick few announcements. Karen, would you please share the announcement slides? All right, thank you. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use. CSTAT can help enhance professionals' knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utesca.edu. Next slide, please. Perfect. CSTAT is launching a new ECHO program, Recovery Science ECHO, on Wednesday, October 18th. This program will meet on the third Wednesday of every month. To learn more about this program, please visit cstat.utesca.edu/ECHO. Next slide. And save the date for our annual Texas Substance Use Symposium taking place February 29th to March 1st next year. Registration will open soon. To learn more, please visit txsus.org. Next slide, please. And reminder to add the Public Safety ECHO series back to your calendar. You should have received the Zoom email today, and all you need to do is click the link in the email that says add to the calendar, download the invite and save it to your calendar. Next slide, please. And join us for our next session on Thursday, November 9th with Melanie on the principles of risk, needs, and responsivity. Thank you so much, Karen. And Dr. Gerber, if you could share the case form and please take it away.
Hello again. Okay. So when I was asked to present a case, and I knew that I would be presenting on ACEs, there's one particular case that stands out so it came to the forefront of my mind when I thought about this individual. Oftentimes we interact with clients, patients, individuals who we may or may not ever see again, but for some reason they leave an imprint in our minds in the ways in which we wished we could have helped them, or that we hope that they're able to address the issues that we saw. And so I decided to present this particular case. So the questions that I'd like to be addressed, and these are really sort of meta questions. What does this substance use disorder case look like from a trauma-informed lens? What may be some of the ACEs at hand here, and how can we best support effective emergency response and long-term treatment and care? And what are larger implications that and needs from our systems for cases like this? So this was when I was working in a alternative sentencing program. It was substance use treatment setting, substance use and mental health treatment setting, but particularly for individuals engaged in alternative sentencing. This individual was a 25-year-old Black male in residential treatment. So my first initial contact with this individual was when he was in residential treatment for 2 months. For substance use disorder, trauma, and periods of psychosis. And this individual had recently, within the week, transitioned to intensive outpatient treatment, which basically means they were no longer living residentially in the treatment facility, but were living off site and coming daily to intensive treatment. Their diagnosis was polysubstance use disorder with a recent history of fentanyl use and spice, which is a synthetic cannabinoid. And this individual came into my office for a therapy session to discuss beginning trauma treatment and began having erratic behavior, started foaming at the mouth and seizing. The strategies I employed, I checked in with the client once medical emergency signs were very visibly displayed. I asked the staff to call 911 and administered seizure first aid until emergency response arrived. And I tried to my best ability to give first responders case context, because primarily when we're dealing with individuals who have a history of trauma, it's very important. And I think sometimes when it's an emergency response, we don't feel like we should, or that we get an opportunity to, but it's really important to give first responders, public safety staff case context. So the agency's standard operating procedure is to call 911 and administer first aid until emergency response arrives. The substances involved, so we can assume, or we assumed, that this individual had recently, probably within the last 30 minutes, used spice, again, a synthetic cannabinoid. Oftentimes they're packaged through head shops or smoke shops in a potpourri package. It looks like a little potpourri envelope. So we found one of those packages in the pocket of our client, and there was previous history of fentanyl, but this individual had not tested positive for fentanyl for approximately 2 months. So a bit of context about this individual, which is very important. This client was adopted from Africa into a wealthy white Christian family in Virginia when he was 7 years old. He began using substances at 12. The adopted family reported consistently that the client experienced nightmares since the arrival to their home. This client had very defiant behavior at school, but a pleasant and kind demeanor at home with his siblings and family. This client had interactions with therapy and various treatments when he was young, especially because he was exhibiting all of these different behaviors, but was sent to substance use treatment at 17 and has been in and out of treatment facilities, carceral settings, and houselessness for the last 6 years. When speaking with the adopted family, they reported a confusion and a disconnect from his engagement with them and the reports that they get when he's in other settings. The adopted family reports that the client came from a highly traumatic environment in Africa. His parents were killed, and he has no contact with other supports or siblings. As mentioned, the adoptive parents had the client in therapy since 6 months after the arrival to the United States. But this client struggled to build relationships with therapy providers, teachers, social workers, and displayed distrust and defiant behavior. The client is 1 year from parents' insurance termination at 26, and the family is worried about the client's ability to access insurance and make health and wellness decisions on his own. The client currently has no employment, on probation for drug-related offenses, lack of stable housing, and has a child in Virginia that is being cared for by the child's mother. So barriers. I found a lack of trauma-informed care by the treatment staff and first responders. And again, when there is an emergency situation, sometimes it can be hard to access that part of ourselves, that empathy, that understanding, to best understand an individual's trauma history. I was hoping that the first responders were able to report this hospital staff, this trauma history to hospital staff and beyond. I tried to communicate the client's history of trauma to the first responders. What would I do differently if prevented with this scenario? I would absolutely advocate for alternative trauma treatments. What I think success might look like for this case, the client must absolutely address childhood and systemic trauma, perhaps incorporating cultural therapeutic strategies, excuse me, and family participation, particularly because it became very apparent to me that the adoptive family had a very different relationship with this individual than this individual had with every other system that he came in contact with. And obviously to stay consistent with substance use disorder recovery and medication management, and referrals made. So unfortunately, the treatment facility that I was working with does not accept clients. Once a client experiences a medical emergency like that and substances found on them, they will not accept the client back. So there was a referral made to substance use disorder and trauma treatment closer to the family in Virginia, since that seemed to be a different dynamic, a different relationship, though the client does not want to return due to wanting to prevent his family from seeing him this way. And that's.
Thank you, Dr. Gerber. Let's open up the floor for discussion. Does anybody have any? Oh, yes, Dr. Montes. Oh, Dr. Montes. I see your hand.
No, sorry, I've been a little distracted. I'm on call today managing a cardiac arrest. But on this case, I wonder with this child's age that, you think about the symptomatologies, 25, and his psychosis. I mean, has he been evaluated for schizophrenia? I mean, this sounds like a pathway where he's self-medicating with, well, now we know why he's self-medicating, but has he been really, really investigated by psychiatry staff for the presence of schizophrenia or depression with psychotic features?
Mm-hmm. Yeah, so that's part of the difficulty when someone is using substances, is that oftentimes many clinicians don't feel comfortable giving such a severe diagnosis of someone who hasn't maintained recovery for a period of time. And particularly with spice can absolutely trigger psychotic episodes. And so the history of psychotic episodes are oftentimes followed by some sort of substance misuse. And so it's tricky when you're giving such a permanent diagnosis and serious diagnosis, right? To think about the implications of what that diagnosis may carry with an individual, particularly when there hasn't been an extended period of recovery, so that we can identify what is what, if that makes sense.
I mean, what I'm thinking about, you said he was in a treatment program for a pretty good long period of time, right? Almost 2 months. I would think that we would have toward the end of the month or so, we'd have a pretty good idea if those psychotic features are coming back, if he wasn't using.
Yeah. Yes. And 2 months can also be nothing, a drop in the bucket, right? When we're thinking about how long it takes for the brain to show marked improvements after a period of substance use, most brain imaging studies show that marked improvement does not happen until about 18 months to 2 years of abstinence or refraining from substance use. So, 2 months feels like a long time, but it really, with a long history of substance use and ACEs, history of trauma, it is a very, very minimal amount of time. Was this individual experiencing any sort of psychotic or any sort of psychosis during the time in treatment? No, because then we would have obviously referred to a higher level of care. But again, it makes it really difficult to unpack the underlying diagnoses in such a short period of time. And again, I want to stress, 60 days, 90 days is great. It's a great start, but it takes at least 1.5 to 2 years to truly see marked changes in the brain, which in turn demonstrates behavioral changes.
I want to jump in and add, Dr. Gerber, thanks for doing that. I love when people talk about ACEs, and I always make it a point that we can't ever just look at this as something that is like them focused or others focused. I think introspection is key. And when Dr. Zanda and Folletti did this study, they also found, while granted to your point, it didn't capture all people, but roughly 50% of helpers and protectors have a 4 or higher ACE score, which is everyone on this call.
Yes.
And
yes.
when I do training and I teach ACEs, very few first responders have ever even heard of this, even though it's been around since 91. Yeah. And what I found very interesting also is when you look at more rural areas to more urban areas, for example, in San Antonio, when I trained all 2,400 of our cops in ACEs, and I would bet you 7 out of 10 of them have a 4 or higher ACE score and have no idea what that even means, why they self-selected into these professions. And then when we train clinicians in other areas like in Iowa or the Midwest and Illinois, it is unbelievable to me how much higher the ratio is of clinicians and social work staff that have higher ACE scores than law enforcement. And they are familiar with ACEs, but they don't know their own score and how it impacts them and how they show up to view the world. So I think it's also important that we look at this through the lens of how does this affect me as I show up to these calls, not just everyone else. And that's
Absolutely.
just a invitation for everyone on the call as well.
Absolutely. Yes, there's a concept in the clinical work called countertransference, which basically means that when you're interfacing with a client that may trigger something from your past or something that an unresolved trauma or issue, oftentimes there's that countertransference of emotional impact. And many of us who are in the helping professions get into it because of some background that we have, some sort of history. And so, yeah, part of understanding trauma-informed care is understanding our own past trauma history, right? And how that may have both given us the purpose to get into the work, but also may trigger a lot of our own responses when we're interfacing with clients.
Absolutely. And I agree with you, Sandra Sanchez, that I also say as soon as a mother is like giving birth to the child and they launch it up on the chest for some skin to skin time, someone should come in and drop the ACE assessment on them and just say like, hey, let's just be aware of what you're about to do to this child. It might also increase postpartum depression though. So we got to be careful.
Yeah. Supports for caretakers should be vital. Given what we know around adverse childhood experiences.
Does anybody else have any questions for Dr. Gerber? Oh, Cynthia. Oh. No. Does anybody else have any questions for Dr. Gerber? If not, Cynthia, would you be able to summarize today's session for us?
Sure. Thank you, Dr. Gerber. This was an excellent training. There are so many things that that just kind of validate on some of the concepts that you brought up. You know, basically, understanding, having a good understanding of and being trauma-informed in trauma-informed care. Other things that are takeaways from this session is the development of that ACE questionnaire and how it's used, ranging, you know, the range score of 0 to 10, and just getting an overall view of individuals' trauma as it's administered. But I think some highlights on this is, you know, it's kind of like, you know, there are a lot of consequences of the ACE trauma. And then what's common is the toxic stress that occurs with this trauma. But there's also, from what I got from the training, is that there's also hope, that you've talked a little bit about some resilience research that says, you know, that pretty much conveys that people are able to heal their brain and their body if they're doing the right kinds of things like seeking treatment and making positive changes. So that's really, you know, that's a positive. Also, what I got from that resilience research is that the stress can stop and replaced with practices that build resilience. And then ultimately making sure that we are surrounded by protective factors, you know, and support systems. So that's what I got out of the takeaways for this session.
Thank you so much, Cynthia. And thank you all for joining today's ECHO session. As a reminder, to earn continuing education credits, please complete the post-session survey using the link in the chat. And if you would like to present a case, please email the Be Well Texas team. We look forward to seeing you at our next session on Thursday, November 9th at 11 a.m. Central. Have a great rest of your day.